opening keynote, which I've been waiting for. And I did switch it up a little bit, Dr. Feras. I apologize for that, but I do think that the topic here, especially given that you are head of the, which I find fascinating, of cardiac surgery and director of robotics, and I'd love for you to touch on your major achievement when you just really transplanted the first robotic heart into a young 16-year-old patient who's doing very well, I understand. So I'm coming to you when I need it next.
So, good morning, ladies and gentlemen. Honestly, it's a great honor for me to be here and in this historical building. Thank you very much for the invitation, and thanks my team and my leadership for involving me in this. So, my name is Feras Khaliel. I'm the head of cardiac surgery at King Faisal Special Program Hospital and Research Center. I'm running the Heart Transplant Center and Assist Device as well as the robotic. And honestly, that's what led into our world's first robotic heart transplants, but I'm going to get into that briefly. King Faisal has been really embarking on a lot of innovation, and with the transformation that we've been working on for realizing our vision, we have established our robotic cardiac surgery program in 2019, and we have been, as a matter of fact, highlighted to become top 5 volume program in the world, as from the first year we conducted 105 robotic cardiac surgery. We kept on going and we kept challenging ourselves. So as you know, or you may know, King Faisal Special Hospital is a quaternary hospital where we receive all our referrals from tertiary hospitals, which is really in between 2 brackets. We're the trash bin. All high-risk cases coming over, of course, with VIPs and royalty from all around the world. And we cater into that, and we did reach 440 robotic cases in less than 4.5 years, where the COVID was among these years and the volumes slowed down. Nevertheless, we continue to innovate and challenge ourselves with certain patient cohort where they used to be the contraindication to go for robotics. Nevertheless, we broke that barrier and we accepted these high-risk patients, whether they are redo surgeries, whether they are morbid obese, etc., or bad hearts. We still take them to undergoing robotic bypass or valvular replacements. So we improved ourselves. We continuously looked into our data and collected it, partnered worldwide with our data, and we did publish multicentric international trials in regards of robotics. Furthermore, we became the trainers leading in our program, where we moved around the world and started training robotic centers and robotic cardiac surgeons in Germany, in the US. We, as a matter of fact, trained Cleveland Clinic for complex robotic approaches early last year. We trained Advent Health, Orlando Health, and Baylor. We formed a group with my good friends Vinay Badwar, who's from the University of West Virginia, and we started a new procedures, which is a robotic AVR, which has never been done except for the last couple of years. We formed a task force where we trained, Vinay and myself, we trained again Mass General Women Brigham Hospital, Mayo Clinic, Baylor, Texas, and Yale University, Columbia, and as a matter of fact, we're meeting in November to start training them on this robotic heart transplant. So we have been, Faisal Special Hospital has been the first worldwide into performing complex robotic procedures, reaching not only single valve or double valve, but triple valve procedures, including ablation as well as ASD in combination or concomitant procedures. We have gone into a fifth redo. Usually, the highest center who performed robotic reached to a second redo, and they never go beyond that since it's the adhesions, the high risk. Nevertheless, with our patient cohort with rheumatic heart diseases and the need of continuous replacement for the bioprosthesis for childbearing age group or younger age group, we reach up to fifth and sixth redo robotic single or double valve replacement, and that's only conducted in King Faisal. We became the second place worldwide to start the robotic aortic valve replacement. As I mentioned to you, Vinny Bandor started it first, and then we immediately moved into next. Nevertheless, we took that into higher challenges, and we started the first triple valve worldwide. As volume-wise, we are top 5 in the world, and compared to big volume centers such as Cleveland Clinic, where they operate 4,000 or 3,800 open heart procedure per year, they conduct 120 robotic valves, so you can calculate the percentage. However, in King Faisal, we only operate 700 adult cases, total of 1,500 between adult and pediatrics per year, but we conduct around 105 robotic cardiac surgery a year, which is all-comer patient. That tells you that almost 22% of our patients goes into robotic. And these are the procedures we conduct, all type of procedures. We conducted the most difficult procedure where there are heavy calcification of the pericardium, and it causes constrictive cardiomyopathy, which is leading to heart failure. And we did totally robotic as well of pericardiectomy, which is removal of this pericardium. And that was 2 months ago. The patient stayed only 3 days in the hospital, and usually they stay up to 12 days due to their RV failure post-opening sternotomy. So basically, our results has exceeded the 97%. To be precise, is 97.6% of survival and no conversion, except one patient in 440 patients. Only one patient was converted to sternotomy. The literature talks about 15% of conversion, but thankfully we're lucky enough not to have that one. And patient satisfaction varying between the age of 14 years of age until almost 80, included in the cohort, which was really apparent in our cohort. And safety is rather crucial and important to look into that, since we film every single robotic case. We go through it, we look at the speed, we time everything, and we even look at the choreography between the team, because this is not a surgeon, this is a teamwork between all individuals in the OR. So look at this. Why do we have to continue performing conventional sternotomy? Yes, it is safe. Yes, it has been done over 100 years. But nevertheless, we're here to embrace the technology, embrace the biomedical engineers who have worked hard in order to manufacture these beautiful machines and devices. Should we use it safely and efficiently? So you can see the 25 centimeter incision in the mid, cracking the chest, breaking the bone, staying 2 weeks in the hospital or more, staying 3 months for convalescence, since breaking a bone takes around 12 weeks to heal. Nevertheless, in our incision, which is not passing 3 centimeter, it takes 3 to 5 days in the hospital, and then maximum 2 weeks of convalescence. So yes, we need to go for that. But what more? I mean, not only you lesser the pain, well, basically they say that the robotic approaches takes the pain from the patient and transmit it to the surgeon, because we really suffer a lot and look into that. Nevertheless, it's a joyful outcome to share that and to continue challenging ourselves. But we did a study in King Faisal and in our patient cohort, and we did find that there were less blood transfusion, 0.25 units per patient, in comparison to sternotomy, where they received 2 units. And these are propensity matched patients. And look at the risk of infection that has been up to 3% in sternotomy for just a low-risk patient versus almost less than 0.5% for robotic mechanical ventilation. In sternotomy, they pass sometimes the 24 hours. Nevertheless, in robotics, it goes 4.8 hours. So almost 60% of the drop is from 11 hours. And the pain and lack of complication, or lesser complication, lesser pain, leads into discharge, early discharge from the ICU. Furthermore, the shorter recovery, we have compared for robotic valve procedure propensity match patient with the sternotomy, and we found that it's almost 6.8 days versus the 10 days or 10.5 days for the valve, and less than 5 days for the cabbages coronary artery bypass graft in robotic approach versus 8.5 days in the sternotomy. Furthermore, cost and efficiency, we looked into that, and we found per 24 patient, propensity match patient compared between sternotomy and robotic, robotic saved $403,000 in these 24 patients. And why? Because less blood transfusion, less length of stay, less mechanical ventilation, less inotropic support. All that lead into the cost, and having faster recovery will increase the turnover, the flow of the patient going to the OR, the flow of patients being admitted and being discharged, and that will double and triple the volume that has been conducted on monthly and yearly basis. And these are simply the procedures again, but I'm going to continue moving on. Global recognition, we have been asked to go and train all these countries and continents and launch clinical trials with them, whether retrospective or prospective, whether randomized or just a translation cohort. And we're running now another one. And our enthusiasm, our team, a great courage, our great support that we have from the high administration, our strong infrastructure did make us think bigger, and we went and we conducted the first worldwide robotic approach heart transplantation. This is the case. So it's a 16 years old young man who has end-stage heart disease with dilated cardiomyopathy, and he started to derange his end-organ perfusion, and he went into renal impairment, liver impairment, was admitted in the hospital, needed IV drips for inotropic support. He was an Intermax 2, which is sort of a very crucial state for a patient to be at. And what we did is basically we, prior to that, about 3 weeks before that, we were not only thinking for a robotic approach, but we started to writing the theory, writing the surgical strategies in order to conduct that, and we took it from theoretical approach into the comparative medicine, where we have conducted 7 robotic heart transplants on cadavers, and we were timing every single transplant and every single anastomosis per each procedure, because what we wanted is safety and enhanced security for these patients, to drop down the numbers, because we need to be less than 4 hours of ischemia in order to have an excellent outcome. And when we reached the 5th robotic cadaveric transplant, we matched the conventional numbers, and at that time we did 2 extras for fun, and for basically to just earn more confidence and to have a better choreography between all the team. Even I remember when we started the first and second case, it was really tearful. It was so scary, despite the fact that it wasn't cadaveric, but it was because we all were thinking real, and the patient is real. And of course, the cadaveric, they liquefy, and it becomes very terrible tissue. Nevertheless, we did it, and a few days after that, we had this patient who had, of course, we did CT scan, we verified our protocol that we applied for our robotic heart transplant approach. And as you see here, I'm dissecting around the heart, around the superior vena cava here, and the ascending aorta. This is ascending aorta, and trying to dissect as much as possible in order to cut down the time once we do the cross clamp and have the heart out of the ice. So here between the pulmonary artery, main trunk, and the ascending aorta, the lower part is the ascending, the upper part is the pulmonary artery. I'm pulling it down to 6 secure the position for cross clamp. This is I'm reaching the arch, and meticulously doing this because the pressure is 120, as you all know, so any sort of mistake you can really go into a bloodbath. So we have to be really careful, meticulous in our motion, and we should never change the practice, and that's what I told my team. We've been doing this over 100, 400, 500 patients, should not change the practice. It has to be the same exact as if it's a robotic approach for valve disease, or if it is a heart transplant approach through the conventional. So this is the left atrium. We always start exciting the heart. So this is the bad heart. We're exciting the bad heart, starting from the left atrium, and now we're exciting the superior vena cava from the right atrium, as you see. Burning, this is a monopolar curved scissor, so we burn and cut in order to ensure hemostasis. The field has to be bloodless, really, as bloodless as possible. I mean, it's challenging, but yet we need to enhance proper visualization for us in the camera, not to have any splash on the camera, because that's our only access to see. And this is looking at the IVC and how we dissect the IVC from the right atrium again. IVC is the inferior vena cava, and you see now we're separating the right atrium, left atrium, and the IVC all together under hemostatic approach, where we do utilize the monopolar cautery. And this is pretty much the last thing. Now the last part of the left atrium, it's been excised. Now this is the last thing you're going to see, and the most beautiful picture is now getting the heart outside from the 6 centimeter incision. And this is the chest empty completely, and now you see the other heart coming back in. So my brother-in-law was telling me, "What did you use, loop?" And I started laughing, and I didn't want to tell him, you know, but then it's true, I did use loop gel. I'm not going to say the name of that brand, but it's good for a person to use sometimes. It worked in here, and it was perfect. The heart slid easily without being squeezed, because this all affects into the edema of the tissue. And we started immediately utilizing the threads into the left atrium, and I have maintenance for that because the thread was a challenge. It was short because it's all made for the thoracotomy, for the conventional sternotomy. So I immediately asked to meet with the CEO, and the VP of Europe came to Saudi Arabia, and we're adjusting this. So we are part of research and development for many companies. Abbott is one of them, Intuitive Surgical is another, and also the Johnson & Johnson and Peters, etc. So these are for sutures, Johnson & Johnson and Peters, and we are developing proper sutures for robotic approach, because, you know, in robotic you don't have the sixth sense, which is the touching. You have the visual sense, and elasticity of the thread has to be well enough, strong enough, in order not to cut the sutures and lose time. We have to be fast as possible. We have to be careful and safe in order to ensure the anatomical position of the heart into the chest, whether you're anastomosing the left atrium or the right atrium, IVC, SVC, or pulmonary artery, or the aorta at all time. Proper visualization from my bedside surgeon, in addition to the whole team, is mandated in this. Conducting a proper choreography between the anesthesia, the perfusion, the nursing, the fluid, and the assistant surgeon and the surgeon. That's to keep calm the room, to keep everyone's nerve down, and in order to accelerate the procedure and ensure success. So as you see here, is we are doing the ascending aorta. We did the pulmonary artery, finished it, and this is the ascending aorta. These sutures are for the vent, for the aortic root vent, in order to remove the air from the heart. And we start that prior to removing the crest clamp and start ignite the heart, basically, to start functioning again. So now these are the last sutures of the ascending aorta being tied together, and after that we go and we insert the pacemaker temporary into the left ventricle. Oh no, prior to that the IVC, of course. So the IVC is being, all these sutures did not change from the normal standards of what we're doing. We respected the sutures, the suture size, the curvatures, the order of anastomoses that we perform in the patient, And because you don't want to have a lot of confusion, you just have one element added into the heart transplant surgery, which is the robotic approach. So as you see, the vent was added into the ascending aorta. We did have another vent in the left atrium in order to empty the heart while we were anastomosing, and we did that. The cross clamp was removed, and we did the last anastomosis of the superior vena cava while we were perfusing the heart. And after finalizing this anastomosis, we start pacing the heart, perfuse the heart up to the standard, where every hour you need to give 15 minutes of perfusion in order to just jumpstart the heart, and slowly and this is the incision. Look at the areola, and the incision is literally double the size of that, which is not passing 7 centimeters. So furthermore, to innovate this, we are thinking of the artificial intelligence, of course, and incorporating that in our surgical field. And we are in discussion with Atari. Atari is the Applied Translational AI Research Institute, which is based in Arizona and ran by my friend Zain Kalbi, who's a robotic cardiac surgeon. And really we need to leverage the advanced artificial intelligence technology in the healthcare application. We are fostering deep multidisciplinary collaboration between interdepartmental or being multicentric departments. We implement strategies and initiatives to revolutionize our surgical process, our health care delivery, and our patient satisfaction and outcome. Extracting multimodal data is super important in order to conduct, to increase the sample size all around the world, conduct these multicentric studies and have a better outcome. And of course, we have to generate a predictive analysis, preoperative, intraoperative, postoperative for patients to ensure avoiding errors, whether it is human error or whether it is a judgmental error or data error. And we are proactively intervening in the healthcare condition to not limit the longevity for the patient. So what we're looking for, the advanced robotic surgeries, the longevity platforms, AI in medicine, and regenerative therapies, and dissecting each one where it can help us proper planning preoperatively and proper management, optimized management intra and postoperatively. This is my last slide. Excuse me for the busy slide, but never just in short is looking at what AI is good for is for the data intraoperatively, also preoperative care, looking at the intraoperative support and looking at the postoperative care, in incorporating the imaging, and which we do CT scan, echocardiography, that can indicate us whether the position of the robot is properly inserted, avoiding bleeding, avoiding lengthy operation and procedure, or failure in repair or in replacement. With this, I conclude my presentation. Thank you very much.